session. Colleagues, I thought we would start with the briefings as we do, beginning with the COVID briefing so that our staff can get over to the county. When we're done with that briefing, we'll get the SAVES briefing. Councilmember Tovo has pulled item number 52. So I think we'll do that pulled item the same time we do the briefing. Since we'll have the staff here to speak on SAVES, that seems to make sense. And hopefully we can get all those briefings done before lunch, anticipating breaking at noon for an hour or so for lunch. We also have other than that, we have the Better Business Bureau pulled item 12. So the staff can speak to that. We'll either do that before lunch or right after lunch. And then we have the executive session today. Economic funding item. Yes, Councilor Kitchen?
I was thinking, and I apologize if I didn't look right, but I was thinking that we had the nursing home report. Is that not today?
Yes, I think that's part of the COVID briefing.
Oh, okay. It's going to be part of that. Okay, thank you.
All right, so if everybody's ready, then we'll go ahead and start. Manager, we'll go to the COVID briefing. Real good to see the numbers coming down as low as they are. I think that's largely due to a community that's so religiously adopting masking. And it's really good. I want to thank the community, and everybody should be proud of one another for doing that. As we go through the numbers, I'm sure that we'll talk about the risks too, but I just wanted to lay that out there. We see, and the reminder that we see right now, 21 states in the country that got to low numbers and are now watching their numbers rise. We have countries, Israel and others, that got to really, really low place and are now moving back to lockdowns. So this is the kind of thing that is, if we lose the discipline as a community, we're going to lose the status that we have right now that's enabling us to open schools and to further open businesses and to have people gather. The science that's being presented to us more and more points to the efficacy of masking and social distancing, that they actually do work. So with that said, I really appreciate our health department, and that's got making sure the community understands that and pushing that messaging really hard because it's just so critical. So thanks, you guys are working really hard. Manager, open that up.
Sure. Well said, Mayor. There are a lot of promising trends that are happening in our community, but that is no reason for us to lay off the important messaging and practices that we have gotten used to over the last few months. Mayor, Council, good morning, and I'm going to pass it right over to Director Hayden to lead off this COVID briefing.
Thank you, Spencer. Good morning. Thank you all again for the opportunity. As the mayor said and Spencer said, COVID is going to continue to be with us. We are at a point where we are seeing quite a bit of things to be excited about, but we must continue the path that we're on. We cannot get comfortable. As we cross over and finish out this year, we must continue all of the efforts that we have in place. We understand that the federal funding will end as of December of this year, but we must continue to provide testing and contact tracing, our case investigations, our surveillance, and our enforcement. Those efforts have really helped us as a city and a county to be in this place that we are in. And so, we have to just flag it for you all that federal funding is slated to end in December. Our epidemiologists and our surveillance team are providing additional support to schools, higher education, long-term care, and other non-nursing home sites. We've added additional nursing and epidemiologists to our team and they are providing more investigations, but then providing some technical assistance and doing some surveillance as needed. We continue to receive word from the state. Last week on the 21st, we received word that the state would be sending us 3 batches of lab work that was going to be sent to us. And that was sent to us late last week. And our staff have verified over 1,300 positive labs. We did have those in our system. And so I think for us, having our Salesforce, which we've changed the name, in place has allowed our staff to query and look up those positives and determine if we had those labs. And so successfully, we had the majority of them. With our testing, we're continuing our testing at Dove Springs, Gibbons, and Walnut Creek communities. And last week, we added the Metopolis Neighborhood Center. Now, each of these locations have day, evening, and weekend hours, as well as our drive-up site at St. John's. And so it's important for us to remember that the services that we are providing, we're also continuing to provide at-home testing. And really for those vulnerable populations, we are willing to come and send a team over to provide those testing for you. Just reach out to us on the website or call our nurse line and schedule an appointment. In order to ensure that we are providing more culturally appropriate services, we did enter into a contract with the Central Texas Allied Health Patient Care Technicians, and they are using some of their students, and they are reflective of the populations to administer the COVID-19 testing. With our long-term care incident management team, we have provided a total of 8,572 tests in 48 long-term care facilities. As most of you know, the governor opened up last week, and so those facilities are allowing family members to come into long-term care facilities and nursing homes. So that has been a change, and we're continuing. Our team meets with them weekly, and we discuss any concerns that they may have. With our homeless update, we're continuing to provide surveillance testing, working with community care and Dell Medical School. We recently did a series of tests of 100 individuals in the downtown area, and there was one person that tested positive. And we typically get them over to our to the isolation facility. We're continuing to do our food access with the Eating Apart Together program to provide those services. Our hygiene services have continued, and we are providing some walk-in services at Terrazas Branch Library. Our downtown Austin Community Court has temporarily moved there, and they are providing case management, basic needs services, and they're also providing masks for our homeless folks. Our Pearl Lodges are continuing. We are working, and we will be providing flu vaccines for our folks that are at the Pearl Lodges to ensure that they get their flu vaccine. As you know, we are really, really pushing the flu vaccine. Last year, our emergencies and emergency room and hospitals were overwhelmed just with the flu season that we had last year. So it's really important for us to really emphasize the importance of getting flu. Flu season starts October 1st. We are continuing with our Protect Yourself and Protect Your Family campaign. And so as of today, our staff have distributed over 4,000 kits. We are providing those kits at various locations in our community, and our website provides the information of at our www.austintexas.ppe for a calendar. We are developing a plan that will take us through the end of the year. On yesterday, I sent out a memo about the high-risk workers memo. It just basically talked about our process of working with the Austin Area Urban League, Austin Voices of Education and Youth, and our Workers Defense Fund. And so they are going to come together and be able to provide a central line for workers to call with questions, but they will receive information, advice, legal case management, information about how to access unemployment insurance benefits. And so any type of assistance that they may need, that is going to be set up for them, as well as the financial assistance. With our childcare and schools, we're continuing to conduct outreach services in our childcare centers that are in our 6 focus zip codes to provide that technical assistance to them. We are transitioning to online reporting for public schools to submit to us weekly. Just as a reminder, we still receive those results as we normally do with any results, but this provides just a second layer for that team to be able to reach out and make sure we're having those conversations with school staff. And this includes charter and private schools. Our staff are hosting a weekly call with the COVID-19 points of contact with public and private schools. And we are doing the same with our higher education. Our environmental health staff continue to provide technical assistance to business owners and restaurants in those same target zip codes, and they are providing services in the downtown area. We're teaming up with Austin Fire Department, APD, and code enforcement on those efforts. We will continue this, what we're calling kind of compliance sweeps. We typically do those Thursday through the weekend. And the goal of that is to ensure the health and safety of our community, but ensure that everyone is in compliance with our orders from our health authority and our mayor. That concludes my report. I am going to turn it over to Dr. Escott.
Thank you, Stephanie. And if I can get AV to pull up my slides. I'll try to get my camera situated here. Okay, thank you, Mayor and Council, for the opportunity to provide an update on COVID-19. Next slide, please. This graph is showing us again the confirmed new cases in Travis County, with the yellow line being the 7-day moving average. Our new cases yesterday were 91, which gives us a moving average of 106. You can see that we've had some oscillation in cases over the past 3 weeks. As Director Hayden said, part of this is due to a backlog of cases that have been reported to us from the state. Last week, somewhere around a third of the cases reported were older than 14 days. Our EPI team is working on a data output that's going to provide us with a daily inventory of new cases versus old cases, or those cases that are no longer active at the time of reporting, so we can provide you and the public some more clarity on a day-to-day basis regarding new versus old. We're hopeful that the backlogs of cases will be resolved as the state has upgraded their system, but we want to make sure that when we do face that second wave, and lab results may be delayed once again, that we have ongoing ideas of new versus old. Next slide, please. Mayor and Council, this is a new slide, and this is showing the active cases. I've included the active cases since our peak back in early July to give you an idea of what our active cases have looked like over the past months. While you have seen oscillations in the new cases, the active cases have been relatively flat. Our current active cases are 692 with a moving average of 716. Again, over the past 3 weeks, it's oscillated a little bit between 650 and 750, but relatively flat in terms of active cases. Again, these are individuals in the community that are capable of transmitting disease that we know of. And luckily, it's been relatively flat with a continuing downward trend, which we're happy to see. Next slide, please. This is a graph of our new admissions. Again, the yellow is the 7-day moving average. Our new admissions yesterday were 4. So again, we had another single-digit day, which is exciting. That brought down our moving average to 13. You can see that over the past week or so, we had a significant bounce in terms of cases with some oscillation or admissions with some oscillations between moving average of 12 and 18. Again, this is one of our key indicators because this is not going to be affected by laboratory delays. It's not going to be affected by new versus old cases. And it is a good predictor of actual case burden in the community. So again, we're seeing a downward trend once again, and hopefully we can continue that downward trend. As a reminder, we want to get under 10 in that 7-day moving average in order to break that threshold for stage 2 of risk. And I'm hopeful that we can get there this fall. Next slide, please. This is a breakdown of 3 things. The blue is our total hospital beds being utilized. The gray is ICU beds, and the orange is ventilators being used. Our hospitalizations yesterday were 78 with a moving average of 85, and that's been flat for the past 10 days. We've been oscillating a little bit, but the trend has been relatively flat. Now, in terms of ICU beds, reported 19 yesterday with a moving average of 26. And again, oscillating in a tight margin between 26 and 28 over the past week. Similarly, ventilators were reported at 16, moving average of 17, also relatively flat over the past week. Next slide, please. This is an update of our breakdown of hospitalizations by week in terms of race and ethnicity. This week, our green line, which represents our individuals who identified as Hispanic on their admission to the hospital, decreased from 50% to 48.1%. And our African American population, represented by the gray line, 15.1% to 12.5%. Again, decreases in both areas. However, we still see the disproportionate impact on our communities of color as it relates to COVID-19. So again, our efforts that Director Hayden mentioned focused on our communities of color will continue. And we appreciate our partners in Travis County, our community partners, as well as those private businesses who have lended their support in providing PPE and other measures to help mitigate the spread in these particular communities. Next slide, please. Now, this is an update of our hospitalizations by age group. The gray line that I pointed to over the past couple of weeks is decreasing. That's our 10 to 19 age group. Last week, it was 7.1% of our hospitalizations. This week, 2.7%. The gray line, the yellow line, the bright yellow line is our 20 to 29 age group. which has seen a continued increase from 13.3% to 15.9% of hospitalizations. So between these two age groups, about 1 in 5 of our hospitalizations in the last week were individuals between 10 and 29 years old. So again, this is to stress the point that these age groups, while they are less likely to be hospitalized and a lot less likely to die from COVID-19, they are still being significantly impacted. And once again, we're calling on our teenagers and our college-age students to be vigilant, to be cautious, to understand that they're not immune from this, and they too must engage in those protective behaviors, the social distancing, the masking, and the attention to personal hygiene to prevent transmission amongst themselves and certainly to other members of our community. Next slide. This is an update of our weekly positivity rates. I want to point out that, again, as we received a lot of old cases, thousands of old cases, both positives and negatives from the state, we've had some adjustments over the past several weeks. Week 35 was previously reported at 4.9%. Sorry, it's, 4.7%, now 4.9%. Week 36 was 5.4%, now 6.3%. And week 37 was 4.4%, now 5.4%. The last week that we're reporting, week 38, 4.3%. Again, we've got some data for week 39, which was last week, which is even lower than the 4.3. Again, these numbers are going to be subject to change as new data comes in. Sometimes they'll move up, sometimes they'll move down. So we'll continue to update these positivity rates as Austin Public Health receives new data. Next slide, please. This is a breakdown of the same data by race and ethnicity. Again, our concern in the past has been amongst our Hispanic and Latinx community, which is represented by the gray bar. You can see week after week we've had improvements in the positivity rate, but still it is the only race or ethnicity that is above 5%. We're happy that it's down to 8% now in week 39, but again, we need to continue to focus on this community to further decrease that positivity rate. All other races and ethnicities are under 5% at this stage. Next slide, please. Again, this is the same data broken down by age group. In the past several weeks, I've talked about the gold bar, which is our 10 to 19 age group. We have seen a significant decline in positivity amongst this group over the past 4 weeks. And we've seen a decrease in the group next to it, the gray bar, which is our 20 to 29 age group. Both of those are above the 5% mark, but we're happy to see the progress of the positivity rates coming down. Again, our young people need to pay close attention. They need to practice the same protective behaviors that we're asking the rest of our community to do. And if we do this together, as the mayor said earlier, we can keep our schools open, we can keep our restaurants and businesses open, and we can continue to keep our case numbers down. The big mistake that we've seen across the country and across the world is pandemic fatigue. People getting tired of these protective actions, thinking that we're safer than we've been in the past. And as Director Hayden said, the virus is still out there. And if we stop those protective behaviors, it will manifest in new cases, hospitalizations, and deaths. As long as we stick to those, as long as we stay vigilant about those, we can keep our cases down, we can keep the hospitalizations down, and we can keep our deaths down. Next slide, please. Mayor and Council, this is an update regarding reports to our Austin Public Health nurse line. As Director Hayden mentioned earlier, right now we're getting phone calls in from the schools to report cases. There's an electronic method that's out there as well that we'll be transitioning to. But this is a briefing of those reports over the past month or so since 8/16. So COVID positive students in Travis County for the week ending 9/26, we had 1 case reported, a total of 24 since 8/16. Staff, we've had 3 positives with 21 positives since 8/16. Close contacts are those identified as individuals who need to quarantine as a result of these cases, 37 for last week and 63 total since 8/16 for students, and staff 7 last week and 53 total since 8/16. Again, the data that we have right now still indicates to us that transmission disease is happening in schools in extracurricular activities, football, cheerleading, band activities like that. And we don't have any evidence right now of transmission between students and staff. So again, these case investigations are ongoing. The contact tracing is ongoing, and we will share information if we do see evidence of transmission between those 2 groups. Again, it's an imperative that people are screening themselves before they leave their house. If they're going to school as a student, if they're going to school as an employee, if they're leaving their house for any reason, they need to do their symptom check, they need to check their temperature, and if everything is normal, then they go out. If it's not, we need them to stay home, be protective, and protect their coworkers and fellow students in the circumstance of students. If we can do that, then we can really decrease the transmission risk in our schools and keep our schools open and healthy. Next slide, please. This is an update of our dashboard related to positivity rates across our community. Again, this is available on our austintexas.gov/COVID-19, one of our many dashboards which are available. You can see that since last week, there's been some significant shifts in positivity rates. Last week, I told you my zip code was twice the community average. This week, it's below the community average. But there's going to be weekly shifts in positivity rates. And this is a way that our community can interact with the data and understand what transmission is like in their community. Again, these are showing zip codes where people live. It's not necessarily indicating where they were exposed. So it's important that folks keep that in mind. But this will highlight the highest increases as compared to the previous week in terms of positivity, the highest percent positives zip codes, as well as the highest increase in new cases in the last week. So it's an incredibly useful tool for folks to use when they're determining their risk for their particular household or their community. Next slide, please. Mayor and Council, this is an update of our long-term care facility dashboard. Again, we've reported 63 cases in the past 14 days. 99 in the past 28 days. And again, this is another dashboard available on our website that folks can monitor for progression in our nursing home and long-term care facilities. Again, we're grateful to our APH staff who are managing these sites and our teams, our task force for nursing homes and our task force for schools who are doing a great job of engaging with those particular communities to ensure that our data is accurate as possible and that strike forces, strike teams are deployed to those entities that are in need. Next slide, please. And Mayor and Council, once again, we're still in stage 3. Our 7-day moving average of hospitalizations is at 13. Our positivity rate right now is between 4 and 5%. So we're still solidly in stage 3. Again, through continued community vigilance in masking and social distancing and personal hygiene, and in particular, that self-screen before folks leave home, we can push this down to stage 2, but it's going to take that ongoing commitment in the coming weeks and months in advance of a vaccine. With that, I'll turn it back to you for questions.
Dr. Escott, thank you. We also want to see the nursing home presentation here in just a moment. But to ask you questions in case you need to leave to get to the county. I have some just real quick. In fact, if the folks could take us off the presentation for a second. Excuse me. Just a couple points I want to just hit on first. Good to see the percentages, all populations go below 5%. There's still a concern that the Latino population is above 5%. Good to see that it's dropping. My recollection is that the percent positivity in the Latino community, which is something that you and Director Hayden obviously are looking at continually, also comparing that data with community care. Community care runs that percentage for its clients. And historically, their numbers for positivity have been much higher in the Latino community than ours, because it's dealing with a Latino community which is even more highly concentrated with essential workers and parts of the community that don't otherwise have insurance. My understanding is that their positivity rate here in their most recent numbers, also for the Latino community, below 10%. A little bit higher than ours at 8 or 9 something, but they've dropped below 10% as well. That's right, isn't it, Dr. Scott?
Yes, sir. And I think their positivity rate for last week, again, they have partial data, was under 5%.
For the overall population.
Correct.
And then for the Latino population, I think it was 9 point something. So I think that's a real good thing to see. With respect to the cases that we're seeing, increased number in students, increased number, both high school, middle school students, also University of Texas students. While we see increases in those areas, they seem to be contained within those student populations and not spreading outside of those student populations into the wider community. Is that correct?
Yes, sir. We're working closely with University of Texas, who is a partner with us for case investigation and contact tracing. And we have not been able to link a student case with an outside member of the community. Generally, they're spreading amongst themselves, and we're really trying to hit home that message. We'd love for them to not interact face-to-face without protective behaviors, protective masking on. But if they're going to do it, it's really essential that they not interact with people in the outside community, particularly those who are going to be more vulnerable, those over the age of 65 and those with underlying health conditions. And I think they're doing a good job.
Okay. And I want to just note for a second and thank you, but especially Director Hayden and her staff for implementing at this point and talking to us now about reaching out to those essential workers to provide the support for isolation, support for income, support for expertise. And I know those efforts have been gearing up, but it was identified as a critical need, and that's up and working now, and it's good to see that. And then finally, today or tomorrow, you're working with me, Director Hayden, to update and reissue the order for the mayor's order associated with COVID, and I appreciate, as always, the direction and assistance that comes from the two of you. I think that probably the update tomorrow or the next day is going to bring us into closer compliance with some of the eviction stuff that's happening at the statewide level in our JP courts. But also we're taking a look at the activity on the bars that are now allowed to operate as restaurants. And I don't know where we are in terms of, I don't know if we're going to wait to see if we have a better indicator or whether it's something that we're going to address now. But there's some concern associated with the operation of the bars that are now open under the governor's order associated as restaurants. but I don't know if this is for you or for Director Hayden. Have we looked at the bars on the West 6th Street area or other areas to see how that activity is going?
Yes, we have a team that with our environmental health sanitarians, as well as our code compliance folks and Austin Fire Department folks. They started the process about 3 weeks ago. And what they're doing is that they're calling them compliance sweeps, and basically checking to ensure that folks are in compliance with the face coverings as well as social distancing, and then looking at capacity in those facilities as well. So they will continue to do that. Initially, when they started, we issued several warning citations, which eventually will turn into an actual ticket once we move it to code enforcement. And so we are seeing more compliance in those areas.
If it's necessary for us to enter an order that says to those restaurant bars type situations that we're going to require the same kind of rules for both restaurants and bars in those situations, so that you have to be seated if you're eating or drinking, and make that apply to the bars that are operating as restaurants with the association, please let me know so that I can make sure that we incorporate that kind of requirement into the orders that we have. And then finally, I would, colleagues and to the community, the University of Texas publishes their dashboard every day, which has the testing that they're doing of University of Texas students. You can see the number of students and faculty showing up as positive. Also with their surveillance testing that they're doing, pop-up testing in the West Campus area and other areas, so that you can track those numbers. There's obviously an elevated number to some degree. It's been coming down as with the rest of the number. And the information we have at this point is it's being contained within those communities. Colleagues, you have any questions? Councilmember Harper Madison.
Yes, I have a few. And given that it sounds like both of us are struggling with a little ragweed this morning, Mayor Adler, that's one of the questions I have as we move into this, encouraging people to get flu shots, and seasonal allergies are just so bad. Is there some sort of indication somewhere where people can determine what's allergies, what's the flu, what's COVID? I mean, when I woke up and my antihistamine hadn't kicked in yet, I know my eyes itching and my scratchy throat. I know what it is for me. But when people, like me, for example, I didn't get seasonal allergies until I turned 40. I think some people just don't recognize the symptoms. I wonder if there's an opportunity for us to let people know what the differences are. The question is for exactly, but it's just something that occurred to me as I'm watching the people around me struggle.
Yeah, and council member, this is one of the challenges with COVID-19 is the symptoms are vague. The symptoms include congestion, the symptoms include sore throat, the symptoms include nausea and diarrhea, which could be a whole host of things. I think the most important thing to remember is if you have any of those things, you don't leave your house. And you can consult with a doctor or your healthcare provider to make a determination if you need to be tested. If you take your antihistamine and it's behaving like allergies and you don't develop a fever in a day or so, it's probably not going to be COVID. But I'll tell you that interviewing many COVID cases myself, that a lot of the symptoms are very mild, particularly in younger people who say, oh, I thought it was a normal headache. I thought it was normal allergies. I thought it was a sore throat, and it wasn't. So regardless of the symptoms, if you have symptoms, regardless of what you think it is, the most important thing to do is stay home and then consult with your healthcare provider to see if you need to be tested.
Thank you. I appreciate that. So I think Mayor Adler touched on my questions around what we're doing to make those numbers in the Latinx community drop. But I think I'll ask a few more questions about that offline. The ISOFAC numbers, I'm curious about, are those rising? Are they dropping? Are we staying flat? I didn't quite catch that if you said that. The isolation facility numbers?
Yeah, those numbers are up and down, and just kind of based upon, because we are partnering with the universities, with that facility as well. It is a community asset, and so those numbers are up and down.
Councilmember, I will just add that there's space. If folks want to isolate outside of their household, which is particularly important if they're in a multi-generational household or if they're living with someone who has significant risk factors, the best thing that individual can do is to go to the isolation facility. It is a free hotel room. People are fed, there's Wi-Fi, there's cable. It's a comfortable place to protect your family from getting COVID.
I appreciate that expansion. And I think it might actually be a great segue into my next question. We talked about masks for certain populations of people, but where I have been receiving some specific requests and making some observations are multifamily complexes, particularly those income restricted complexes. I haven't to date seen a system outside of the community sort of coming together to do drives and such. Is there any intention for us to do a more comprehensive effort around multifamily, especially the sort of, the lower income restricted complexes, to do PPE, specifically masks?
I think what we may need to just follow up with you outside of the session, to kind of determine exactly what you are kind of thinking about and what you were hearing.
Okay.
Our staff have reached out to HACA and has had conversations with them, and so you and I can maybe address it outside of this session.
That'd be great. Thank you, Director Hayden.
Mm-hmm.
Education pods. I'm hearing more and more about people doing the pods. I just have some questions. I heard, public school, charters, private. I didn't hear anything about pods. And so if we have people that are putting, 10 to 12 kids together, is there any, I don't even know how we would go about tracking that. And so I'm just curious about what that might look like. And it's not a question that I necessarily need an answer for today, unless of course it's something you are already working on. It's just something that's on my radar as a point of concern.
We are already addressing those pods. We have a couple of contacts that actually work for the city that are working in the community on that effort. Our staff have put together some guidance and issued that, and we've also put it on the website. And so that information typically also comes in through our education line, through our nurse line. And so that's how it has been brought to our attention. So we are working with them. As we find out they exist, then we provide the technical assistance and the guidance to them.
That's helpful. Thank you very much. And I think the last question I have is, Dr. Escott, you made reference to the second wave. I'm curious about what that timeline looks like. And then what should people be doing right now while we're relatively flat before we get to that place? For example, dentist appointments that you missed because our numbers were high. What should people be doubling down on doing right now before we get to that second wave?
Councilmember, I think it's critical for folks to understand that we can avoid a second wave, or it could look like a wave that you wouldn't want to surf on, because it's about protection. It's about continuing those things, that masking and social distancing and personal hygiene and that self-screening before people leave home. If we do that, we can push this off until we have a vaccine available. Right now, it's important that folks take care of those things that they've been delaying. the dental visits, the physical examinations, and importantly, their vaccinations. It's really very important that folks get their flu shot this year. And that is an epidemic that we have a vaccine for right now that's very effective. And if we can eliminate that as a risk for this community, it will certainly help us if we do see a substantial second wave in Austin. As I pointed out to Commissioner's Court last year, during the peak of flu season, we almost ran out of ICU beds. We can't tolerate a bad flu season this year. We really need people to be engaged in getting their flu shots, which are available from pharmacies and Target and people's employers, and of course their physician's office.
So I appreciate that. So it sounds to me like what you're saying is it's not inevitable, this second wave, but given the current trends, if it were to happen, when do you think that would be? Are we talking October, November, December? I'm just having a general idea, just given the current trends, if we could project based on that. I do appreciate that you're saying it's not that it's inevitable, but if there's something people need to be preparing for, I think more information is better than less.
Yeah, Councilmember, the answer is I don't know. The answer is generally when we look at second waves, it's when people grow tired of all the protection and they say, I'm done with this. And then we realize why we were doing those protections, because it hits hard. I think if we can avoid that, then we can push off a substantial second wave indefinitely. But the timeline is based on individuals in this community. And, when are we going to see increased risk for the burning of the masks? We're going to see it at Halloween. We're going to see it at Thanksgiving. We're going to see it at Christmas, because people want to be more normal during those holidays. If we can resist that temptation, then we can ride through the winter without a substantial second wave.
Thank you for that. I heard a song the other day that said, just because you're over it doesn't mean it's over. So I think, and then the last thing I'll say is just the hospitalizations by age group slide that you showed. Would you mind showing that one more time, please?
I'll ask AV to pull that up.
Which slide number is it?
It was the one that looked like a very creative small person drew it. This one.
That one.
I don't know about any other layman, but I find this tough to follow. I wonder if it could be more graph-like. I find this one tough to follow.
We'll see if the team can work out a way to display it a bit differently. The challenges we're tracking over a long period of time, so it makes it more challenging. We could chop off the more recent data to give you a smaller snapshot. But we'll work with the team to see if we can display this better.
I don't know about anybody else, but yeah, my eyes go crazy on this slide. So it would be very helpful. And then the very last one, there was a slide that was by zip code. I just missed the number that talked about 78723. If I could see that one more time. And then that was all I had. Thank you. That's it. Thank you very much. I appreciate y'all.
Mayor? You're on mute, Mayor.
Councilmember Ellis.
I appreciate that. Are there any opportunities to speed up the results of the testing? I didn't know if that was reliant on the process for getting those results or if it was a supply issue that we might still be dealing with.
Typically, our results return 24 to 36 hours is the typical turnaround time, because that is a PCR test and it is being sent to a lab. So that's actually really good time. Now, if you're using a different type of test, which we are not, antigen tests, then you can get those back in about 20 minutes.
Councilmember, the delays that Director Hayden and I described are from outside labs. So what happens is a clinician orders the test, and the clinician may report the test results to us, and the lab reports it to the state, and sometimes to us directly as well. What happened was a delay in the state reporting. So they had data feed issues going into the state system, which meant data delays coming back down to us. Again, I think, the state, with the state's upgrade in their system, we should avoid significant future delays. But again, I'll point out that these data feeds, a lot of them are brand new. They didn't exist before March of this year. So part of the challenge we've had is playing catch up. And again, I think this goes to underlying underfunding federally of public health data infrastructure in order to prepare for events like this.
I can appreciate that is a high hurdle to be navigating as this has proceeded. When I see that there's a rapid test available at, say, a private pharmacy, is that information that's still being fed into your databases?
We do receive notification regarding the antigen tests, the rapid tests, as well as the rapid PCR tests. Our team is working on displaying the probable cases, which is what you get if you have a positive antigen test, so that we can display both the confirmed cases and the probable cases.
Okay, that's helpful. And then, are there any resources available for some of the quick read thermometers? I know some people may be trying to do their own temperature checks at home each morning to make sure they're being responsible. And I wasn't sure if the city had some available or through a private partner for those who may not be able to access one.
I'm not aware of resources we have. I know thermometers are challenging to get. I ordered some of the instant thermometer, the disposable ones, back in February and still have not received them. So I know that's an ongoing issue, and I'm not sure if Director Hayden might have any information regarding availability of those.
We have provided those to some of the childcare facilities. We've provided those to some of the nonprofit partners that did not have the access to those. But as Dr. Escott has stated, those are a little difficult and challenging to receive. But we've provided those on a smaller scale. It's not something that is widely distributed in our community.
That's helpful. I wish there were more of that. We could have more access throughout the community, but I understand that. That's all the questions I had. Thank you.
You're welcome.
And Mayor, you're on mute again.
Thank you. Sorry. Any questions before we go to nursing homes? Councilmember Tovo, then Councilmember Cassar, then Councilmember Alter.
Thanks very much. And Mayor and colleagues, I'm going to jump over for a little bit to the Austin event at 10 to welcome the new superintendent. So I'm going to miss a little bit of this. So thanks for calling on me, Mayor. Dr. Escott, I wanted to go back to the slides that you had about students. This is such a conversation in our community right now. And so I appreciate your information and that you provided, but I want to be sure I'm understanding it. I believe it's slide 11. So as I understood your comments right now, the general summary that you offered is that students who are testing positive appear to be primarily within extracurricular activities such as football and cheerleading and band, and that there have not been cases of student to teacher transmission. Was that the correct? Was that summarizing? Was that summary correct?
That's correct. In our last discussion with our EPI team, they have not seen any transmission between students and teachers.
And are you seeing any student to student transmission within school settings that have reopened for in-person contact?
We have not yet seen any student-to-student transmission within a classroom type of setting. We have seen student-to-student transmission in those extracurricular activities, and certainly in social settings outside of the school setting of students.
Thank you. That's helpful to know. And so on this slide, I understand the first couple of categories, the close contacts. Can you, you addressed this in the presentation, but I didn't understand what it was. What is the student close contacts? Is that 37 people who were within close contact with the positive students noted above, or what are those last two categories?
So those are students and staff who had close contact with a positive case. So these were people within 6 feet for more than 15 minutes, necessitating quarantine of those individuals.
I see. So those aren't COVID positive. Those are just individuals who are now isolating because they were within close contact with individuals who had, okay. And they
Correct.
had come into contact with them in a school setting of some sort.
I'll have to clarify with the team if these are only related to those school cases or if those include individuals who are isolated because of external close contact.
I see. Thank you. And then I have a couple of quick questions about the slide that I think is slide 7 that Councilmember Harper Madison asked you to look at as well. So either I misheard or I think you may have reversed a couple of the colors in your description of it. So I just want to be sure that I'm reading the graph correctly. The 10 through 19 here is actually the light gray. Is that correct?
Correct.
So those numbers, it looks like, are dropping, but the gold 20 to 29 are actually increasing as I read this graph.
Correct.
Okay. And of that 20 to 29 population of numbers that are increasing, do you have a sense of how much of that is or are college students, are individuals associated with some of the universities in our area? I could certainly compare it to UT and some of the information out there about our other institutions of higher learning, but just wondered if you had any kind of general comment about whether
I do not have
20 to 29-year-olds are.
I do not have further detail regarding that age group. I can tell you that, let's see, in the last week for the 10 to 19 age group, one individual aged 11 to 13 was hospitalized. 4 individuals aged 14 to 17 were hospitalized, and 2 aged 18 to 19 were hospitalized.
Okay, thank you very much for that information and for these for the range of information that you've presented today. I know that you had a conversation last night with the Board of Trustees, AISD's Board of Trustees, and you may have touched on some of the key points today that you presented there, but I also just wanted to ask you or invite you to offer any information or findings or conversation that you think is relevant for us to know coming out of that presentation or that conversation that ensued with AISD leadership.
Certainly. The conversation I had with them is that I believe that given our positivity rate, as well as the protective measures that have been put in place by AISD and our other school districts, that now is the time to open to that 25% level. I think our community as a whole has been more protective than others around the state of Texas. And I think that's particularly true for our school reopening process. We've demonstrated that opening at 25%, allowing teachers and students to adopt and adapt to the new guidelines, to the new procedures within that school space, allows valuable time to learn how that works, to modify if necessary in those first couple of weeks, and to make changes before they bring in additional students. Ultimately, success depends on people being engaged and doing that self-screening before they leave the house every day, engaged in wearing the masks, engaged in the social distancing and the hand hygiene. So really have multiple layers of protection that are built in to keep schools safe. And I think the school districts that have opened so far have been doing a good job of that, and I expect that AISD will as well. This does not mean we're not going to see cases. We will. Our goal is to avoid substantial outbreaks, sustained outbreaks within schools. We can expect we're going to see, one-off cases come or small clusters come. But if we're successful at identifying those close contacts and quarantining them appropriately, then we can avoid those sustained outbreaks. And again, I applaud AISD as well as the other superintendents who we've been meeting weekly with for months now to develop this plan, to refine the plan, and to implement strategies to mitigate the spread in schools.
Thank you very much. Thank you for that. And certainly reassuring to know that all along you've worked so closely with the schools, especially as they begin to reopen. So thanks. I just want to make one comment about the flu shots. I appreciate really the efforts that you and our public health department generally have made over these last weeks about encouraging people to go get their flu shots. I know in my household they asked, why are we going to get flu shots when we're not leaving the house all that much right now and not going to school? And we talked about, how this is really the time to do it. No family, even if they're in the fortunate position to be able to work from home and attend school from home right now, nobody can mitigate their risk to get flu shots. So thanks very much for continuing to get that message across our community. That even though we have less social interaction and our schools aren't open up at 100%, it's still really the time right now to get those shots.
Thank you, Councilmember Tovo. Dr. Escott, I recall that flu shot is being recommended for everyone over 6 months of age. Is that right?
That's correct, Mayor.
Even some of the youngest among us. A great family bonding activity.
That's right.
And go get flu shots. Councilmember Kassar.
Thanks. So I really appreciate the high-risk worker memo and strategy kicking off. Director Hayden, do we know what dates more or less that all goes active?
It should be active now.
Great.
I'll double check with staff, but it should be active now.
Great.
We wanted to make sure that we added the call center component and the outreach component with those two vendors, because then that really helps Workers Defense really focus on those 4 areas of providing that direct assistance and financial assistance.
No, I think that's really important. We keep hearing from folks that have had COVID and that are really struggling, and so this is really helpful. Dr. Escott, on the hospitalizations by race and ethnicity, it seems like the most disproportionate impact, while there is a really disproportionate impact in the Latino community, the most disproportionate impact in hospitalizations now seems to be in our African American community. But then on positivity rates, it seems that the highest disproportionate impact is in the Latino community. What takeaways should we have given those two facts?
Councilmember, I think that the takeaway is that we've got to address the underlying health conditions in our communities of color. We've got to address access to care. We've got to address the social determinants of health, which we know underlie all of these things, not just for COVID-19, but for flu and cardiovascular disease and diabetes and obesity. We've got to stop ignoring these things in our community. And, I think that we've got a lot of work to do over the next decade to create more equality in terms of these social determinants of health. If this is a measure of how we are as a country, how we're doing as a country, we're failing.
I agree with that 100%. And I think that is the key takeaway. One last question then, though, is we're seeing higher positivity in the Latino community, but then higher hospitalizations in the Latino community, but even higher and higher than that in the African American community. But we don't know exactly why that might be. It might be because Latinos skew younger, or it might be for a variety of things that we don't understand. But just in the end, we have high disproportionality in both groups. And if I was asked that question, is that the accurate thing to say, or is there something better, a better explanation?
No, that's correct. That's the accurate thing to say. We are looking at those factors in a bit more detail to see if we can sort out a pattern. The challenge is that we've got to wait until we have more data points to make any scientific determinations about things like risk of hospitalization based on ethnicity and risk of death based on ethnicity, because we generally need large numbers to prove anything scientifically. So we are collecting that data. We are sharing it with researchers that we're partnering with, and hopefully we'll have a better answer in the coming months.
And then I just have one last question, which is, I really appreciate y'all putting together this map that shows the amount of tests and the positivity rate in these different zip codes as it updates. I think that that's really helpful. My quick scan of it seems to show that we are doing a lot of testing, especially in the places that need it the most, but I didn't go and check every single zip code on the map. Are there any lessons learned or anything that is standing out to us based on that, on that map of the new data you will have put up? Is there anything that we see there that makes us say, hey, we need to do more of this?
I think we may want to, we provide a nursing home cluster report, and there may be some additional surveillance that we may need to do, and do some more targeted testing, and add the surveillance to it. We are having those conversations now about what that would look like based upon that report. But the strike teams that we've established, they are covering the areas where we're seeing more positive cases in those populations.
Thank you.
For Alder.
Good morning. I wanted to, first of all, thank my colleagues for asking some really good questions. I think you covered a lot of my questions. I did want to ask Dr. Escott if you could clarify the access on slides 6 and 7 that says percentage. Are these graphs of like the percentage of the cases by ethnicity? Or is it, because it's not the percentage, I mean, because the number of cases is going down. So taking this as a percentage, it still tells us something, but I believe we're making more progress than this chart suggests on slide 6. I wanted to make sure that I'm understanding the percentage on that one and on 7 as well.
Yes, Councilman, the denominator is total number of individuals hospitalized in the MSA for that week. So this is really designed to identify how are we doing in terms of the disease impact on races and ethnicities as compared to their representation in our community. So this is the way we've chosen to display it. We'll certainly look at other options. I agree with what you said. Our total hospitalizations are going down. Our admissions are going down. So you're looking at smaller numbers of individuals represented by this graph.
Yeah, I think it'd be really helpful to have a some sort of comparative chart that has the numbers charted by race over time, because I think this is masking some of the progress. And while we still clearly have to target resources to certain populations, given you know, everything that my colleagues have already said and the positivity rates and the disparate, I do think there's more progress than these charts allow us to see. And similarly, in slide 7, if the case numbers are going down, again, this is for the layperson, since this is the percentages is capped at 100, there's only so much movement that can happen. And so I just think it would be helpful. Maybe we have that elsewhere. I was focused on that one. I know we have positivity by group, but in terms of number of cases by group, I think it would be helpful to see that over time. Related to that, for the schools, Councilmember Togo asked a lot of my questions, but I was, you know, since at least my experience with AISD is they're not open yet. What portion, you know, where are we seeing the schools opened? And what have been the experiences in either the other districts or the private schools? Because, you know, as I'm aware of with AISD, it's mostly been the extracurricular activities that are there. So to say, well, we haven't had spread in the schools, if the schools aren't open, doesn't mean a whole lot to me. So, but I don't understand the magnitude of the other schools and their opening and their experiences and what percentage they're open, just because I don't have that information. Can you give us a bit fuller picture?
Sure, Councilmember. So every other school district outside of AISD, to my knowledge, opened to 25% the day after Labor Day, and are now at 50%. So the numbers I shared are with every other school district already up to the 50% mark. Generally speaking, in hearing reports from our superintendents, the percentage of students requesting to be in person ranges between 40% and about 55%. So there's still a significant portion of students whose families don't want them to do in-person classes. And that's fine, and I think that contributes to you know, the success of mitigating the risk. I think it would be much more challenging for us to mitigate the risk if there were 75% or 100% of students in the classrooms. So I think that is helping to protect those other school districts at this stage.
Great, thank you. That's really helpful. And then my last question, I think, is for Director Hayden. You spoke about the ISOFAX and the ISOFAX having space. Can you tell us about the protective lodges?
The protective lodges are relatively full. As we move individuals out into permanent supportive housing, that is the goal with the folks that are there. So our plan is you know, with those facilities being as full as they are, and the goal of needing to move the individuals out by the end of the year. And so, you know, we are working very closely with our emergency shelter folks. They each have plans in place in order to, you know, not have too many folks there as well. But relatively, those protective lodges are full.
Thank you.
Mm-hmm.
Colleagues, anything before we go to the nursing home report? Let's do that then. Director Hayden.
Thank you. Mayor and Council, on May the 7th, you passed a resolution directing the city manager to collaborate with the Design Institute for Health, Dale Medical School, to analyze, evaluate, and identify approaches for system improvements to protect the residents and reduce the risk of spread of COVID-19 in nursing homes, assisted living centers, and other long-term care facilities. We've had the Design Institute to come forward and do a presentation. They are back to provide the second phase of their work. We sent a letter and the full report to mayor and council. Thank you to Katie for ensuring that you have the longer report. And so we have our staff from Dale Medical School, Mr. Stacy Chang, is going to do a presentation. I will turn it over to Stacy at this time. Thank you.
Thank you, Director Hayden. I appreciate it. And thank you to the mayor and council again for having me here to present. And a special note to Austin Public Health in particular. You all have continued to be very actively engaged, partner in this effort, and for that we're very, very grateful. So if we go to the next slide, as a refresher, if it asks AB to move to the next slide, thank you. As a refresher, as Director Hayden mentioned, this study was commissioned by a council resolution introduced by Councilmember Kitchen earlier this summer, and it recognized that the COVID-19 pandemic will be an enduring risk for residents in long-term care facilities, even when the threat to the general population may fade. The goal of the study then is to identify broader scale system issues that our current pandemic response hasn't had time or capacity to consider. And then to develop responses to protect the residents and staff from the pandemic and similar crises in the future. Next slide, please. The phase 2 objective, and when we were back in front of you in midsummer for the report on phase 1, I shared initial insights from that first phase. I'm here today to share the outcomes of the additional research we did since then, in other long-term facilities and with other people in the system, and also, more importantly, the strategic opportunities that have emerged. These opportunities represent the possibility to make real and substantial change to reduce the risk and burden of this pandemic on those in long-term care, and we'll spend a substantial amount of this presentation sharing those. Next slide, please. As Director Hayden noted, the full report is in the hands of the mayor and council. I think it's also available for public download as well. I only have enough time this morning to share an executive summary of the work to date. There's a tremendous amount of additional insight, perspective, and commentary compiled in that full report, and encourage you to read it if you're interested in the additional detail. I'll also save some time at the end of this presentation to entertain any questions or commentary you might have. Next slide, please. In the overarching project timeline, we are here at the conclusion of phase 2, which represents the end of the research effort in this project. In phase 3 and later, we will take what we've learned and begin standing up actual solutions. The next immediate phase will focus on design and development of these solutions in collaboration with the stakeholders and domain experts with whom we've already been working. That will be followed by deployment and testing of prototypes and evaluation of impact. Our goal is to see these solutions into implementation, along with recommendations before the project ends. The funding from the city was allocated to support just the first 2 phases of work, which concludes now, but local philanthropy has committed to support the remainder of the work, for which we're also very grateful. The funding from the Michael and Susan Dell Foundation in combination with the city support represents, I think, a very unique collaboration, something we're proud to be at the center of. We've been asked to return to City Council to report back on the subsequent phases of work, and I look forward to keeping you apprised of our progress as we move forward. Next slide, please. As before, we're working with a pretty broad coalition of stakeholders, represented in part by the steering committee for this project, but also by the many facilities and operators we've met in this project. Next slide, please. By way of overview, this is the comprehensive summary of the facilities we visited during our research. We expanded our research effort in phase 2 to include assisted living and independent living facilities, as well as a Texas State Veterans Home and Marbridge Foundation, which serves individuals with intellectual and developmental disabilities. We also expanded the geographic coverage of our investigation, but you'll note that in spite of no shortage of effort, we weren't able to visit any facilities east of I-35. Participation from facilities was strictly voluntary, and every facility we contacted, and we contacted every one of them, on the east side declined for various reasons. It's important to note that only about 10% of all facilities in the county are located east of I-35, which made it hard to find one who would participate, but also raises an important question about potential inequities in access to these kinds of facilities, which I'll touch on later, and which Dr. Escott touched on as well. Next slide, please. When I presented in July, I shared a pretty substantial amount of context about the nursing home industry, primarily to ensure we were all starting from a common foundation. I won't review those here, but the report contains this refresher for your reference. If we go to the next slide. For phase 2, just to ensure we don't get lost in the terminology, I do want to provide a few clarifying definitions. Assisted living facilities serve individuals who need assistance with activities of daily living and also minor medical care. Residents there generally aren't able to live on their own, but they don't require the 24-hour skilled nursing care that's necessary for full-time medical care like you see in a nursing home. Independent living facilities do not provide medical care, and residents generally choose to live in these facilities for the social connection and activities, and also for the lowered burden of having to maintain their own home. Most assisted living and independent living facilities are private pay, with some exceptions where insurance and other benefits can be applied. Assisted living facilities, because they provide medical care, are regulated by federal and state health and human service agencies. Independent living facilities are not regulated by HHS, and we'll come back to that because there's some salient relevant points to that. Next slide, please. Just as a reminder, this is how long-term facilities are distributed regionally. Again, only about 10% of those facilities are east of I-35. This list here doesn't include independent living facilities since they aren't regulated by Texas Health and Human Services Commission. Next slide, please. In phase 1, when we shared back in July, we highlighted 4 initial insights. And just very briefly in summary, insight 1 was about the gap between the theory of how infection control protocols should work and how in many ways they are fundamentally misaligned with the realities inside a long-term care facility. The second insight was about the unending stream of evolving guidance and recommendations that the facilities receive and the strain it puts on those facilities to interpret and operationalize that guidance. Insight 3 detailed the significant sacrifices and risks that staff endure and the kind of pressure COVID is putting on that staff's daily lives outside of work. And then the fourth insight really focused on the emotional and mental burden that residents are enduring, mostly as a function of isolation, that then exacerbates the burden on the staff that serve them. Next slide, please. There are a few more to share from this second phase of research, and I'll delve into these in a little bit more detail. Insight 5 pertains, which we're calling aging in place versus resident safety. That insight pertains to senior living communities that offer the full spectrum of independent living, assisted living, and skilled nursing facilities on one campus. The promise in those communities is that as a resident needs more medical assistance over time or support for activities of daily life, that they can age in the same place where they have developed relationships and a social network. In a COVID context, there's one very significant consequence to that arrangement, however. Facilities tend to adopt the strictest guidance across their campus to protect the most vulnerable residents. And so if they have a skilled nursing facility on campus, they will put some very significant restrictions appropriately in place, which then restricts the freedom of those in the assisted living and independent living scenarios. In this case, the very benefit that residents came for, which is the continuity in their care experience over time, actually then becomes a restriction on the quality of that lived experience, which is in this moment still an unresolved tension. Insight number 6, which we're calling the price of wellness, is directly associated with the source of revenue for different kinds of facilities. So assisted living and independent living facilities are primarily private pay, which means they generally have more revenue and more freedom in how they utilize that revenue, which translates really frankly to a higher quality of experience for both residents and staff. By contrast, most nursing facilities serve poor patients who depend on Medicaid for funding. That reimbursement provides much less than private pay, meaning that these facilities have less to work with and less to offer. This discrepancy is an inequity directly tied to wealth, and it means that not everyone has equal access to quality care. This may be somewhat obvious, but it's important to call out and actually make plain. Next slide, please. The last insight is around the impact of trust in really culture and leadership. It really can't be underestimated how much leadership and then the culture that flows from that leadership affects the experience of working and living in these facilities. The quality of communication, the transparency with which leadership acts, and then the resulting trust are all quite critical factors when it comes to retaining staff and ensuring they are productive. While building a positive culture is essentially free, it's not without work, but it is essentially free. Not every facility understands or has mastered the necessary elements. And we saw quite a variation and distinction between facilities on that front. Next slide, please. In addition to the facility visits, we also deployed a survey for family and caregivers of residents. 5 facilities took part in the survey. We got 85 responses in total. In the survey, we asked family about how residents came to live in these facilities and about their experience during the COVID lockdown. Next slide, please. There were 2 primary takeaways, the first of which should be familiar. In the first one, family members reflected their concern about their loved ones and their potential decline due to the isolation. The second takeaway revealed that the quality of visitation experiences during this lockdown really depended heavily on individual circumstances. There was no one universally perfect approach to visitation, even in places where facilities had figured out some version of an in-person visit, either through a window or outdoors. This is something I think that we'll want to keep in mind as we move towards solutions, especially with regard to Governor Abbott's recent order to reopen visitation in nursing homes. There will not likely be a one-size-fits-all solution, and we'll have to be creative and conscientious about what we deploy. So if we'll move to the next slide. So I want to spend the remainder of this presentation talking about what we call strategic opportunities. I want to frame this for a second first. The bulk of this effort in this phase of work really was to make sense of all that we had learned and to begin to describe not just what was broken, but what we can actually do to fix it. I want to make the point that strategic opportunities, the ones I'm about to share, are an expression of what is possible, but definitely not a prescription of what should be done. These are starting points for new solutions. They will be evaluated and developed with experts that we've already engaged with in the upcoming phases to determine whether they're feasible, they're viable, or even if they're desirable for the end users. Some of them are straightforward to implement, changes to communication, protocols, minor changes in space. Some are much more complex to implement, care models, organizational change, policy, and system dynamics. Importantly, none of them come for free. They require time to plan and budget to realize, and for facilities and operators and even public health departments, additional resources are going to be necessary to see them come to fruition. So with that grounding, if we go to the next slide, we've categorized the strategic opportunities into 5 categories. The first is infection control, by far the largest, both for COVID-19 and what may come next. Second category is staff well-being, followed by expansion and evolution of staff roles and responsibilities. The fourth focuses on staff retention and the incentives to help make that happen. And the fifth focuses on resident well-being. Next slide, please. We've actually identified 35 distinct areas of opportunity, and we further stratified them by what you see on the left side of this chart, which is what we call now, near, and far. Those represent the potential time, effort, and general resources necessary to realize them. By way of illustration, I'm only going to highlight a subset in this presentation. There's no chance I could get through 35 and do all of them justice. But I've chosen a subset to highlight what can happen at the facility level, some that might require coordination at a regional level, and others that need to consider policy shift at the state and federal level. I do encourage you to read through the report to get a sense of the full set. They are a rich set of opportunities, none of which I think should be ignored. Next slide, please. The first one I'm going to share is in infection control. We called it Building Depth in Knowledge. We found that many staff saw the new procedures for infection control merely as a set of rules that they had to abide by. And when rules feel arbitrary, it's hard to adhere to them. We're asking, how might we foster a deeper understanding of the why behind infection control protocols so that staff are empowered to take action through better understanding and knowledge. We saw significant variation in the way different facilities approach education around infection control. Those that took a more participatory and staff ownership model saw much greater compliance. And we think there's an opportunity to develop approaches that all facilities can adopt in this area. Next slide, please. There is no single source of truth for infection control guidance right now. For facilities and operators, it's hard to know what guidance is most important or most impactful or the first to deploy. It's hard to identify who has the authority to answer specific questions when they arise. And it's mostly a one-way street. The facilities are recipients of information. It's hard for them to capture a response or data that helps authorities refine their approach. And so we're asking, how might we alleviate facilities' burden of accessing and interpreting infection control guidance so they can focus their attention and energy in a more beneficial way? We believe there's an opportunity to develop a common platform that can be accessed by everyone that is a two-way street and helps both those setting guidance and those acting on it to be more effective in that exchange. Next slide, please. The third one here is what we call equitable access to resources. And this is not a new topic. Large operators, when COVID hit, could manage to muster the operational ability to coordinate supplies for their facilities. There's some very heroic stories about individuals in facilities essentially finding PPE for their staff. The individual operators, the ones that own and operate just a single facility, were left to their own devices and really did struggle for a period of time, and that struggle is not over. In many cases, the right amount of PPE is not always present. So we're asking, how might we ensure timely, adequate access to resources critical for infection control, specifically PPE during time of crisis? The topic of a regional stockpile of PPE is not new, but it's an important one for us to consider. Next slide, please. I want to share one example from the category of staff well-being. We learned that many staff feel like they're on their own, right? Certainly when they're in the workplace, they get support from their employers and fellow staff, but once they're on their outside, they're very much fending for themselves. So things like personal and family needs, mental health needs, forms for collaboration, and especially if those staff get sick, they need assistance for what can be a pretty significant burden on their finances if they need to quarantine away from family. So we've asked, how might we address staff burnout by implementing support systems both within facilities and across the field to prioritize staff well-being, because keeping them well is a key to keeping the residents in the nursing homes well as well. Also. Next slide, please. In a moment when a lot of these facilities are understaffed, there is an untapped pool of resources that we call volunteers who want to help. They are essentially a free resource, but in this moment, there's no way to take advantage of them or to quickly onboard them if they were even allowed in facilities. So we've asked, how might we redefine and expedite the qualification of non-essential staff as essential staff in order to create a labor pool capable of supporting the facilities? There's a real opportunity and real need for that, and potentially something to explore going forward. Next slide, please. We know that the pandemic put a strain on staffing, everything from limiting frontline workers from being at multiple sites to additional demands on their work in a site to covering gaps created by other staff who might get infected and have to quarantine. Austin Public Health has already deployed responses to this. So it's a great foundation, but we're asking if we can address these demands on the system in additional ways that include other health professionals such as government workforces like EMS or search and rescue, or even volunteer firefighters, or even health profession students. There are potentially creative ways for us to back up the demand on the overburdened and overworked staff that are currently in nursing homes. Next slide, please. it's interesting. I noted this before. There actually isn't a great depth of knowledge in management science in long-term care, whether in crisis or not. We've seen evidence of better practices in certain facilities, and we're asking here if there's a way for us to codify those practices to share across the system to ensure the same level of sort of competency from a cultural standpoint within facilities. And then I'll share 3 last ones from the resident well-being. Next slide, please. We've seen significant variations in facilities and how they allowed residents to interact with each other. And if you recall for a moment that one of the value propositions of facilities like this is the chance to socialize with others. The facilities that have figured it out, a way to maintain some of those social connections between residents, are seeing a much better response in the emotional and mental health of their residents. So we're asking how might we balance engagement between residents with appropriate infection control in order to ensure the quality of life and socialization in these facilities. Next slide, please. With Governor Abbott's order to open up visitation to family and friends, there will be a lot of immediate work, a flurry of work, I think, to accommodate those rules. But we're also asking in the midst of all that work, if there are ways to develop more permanent solutions that are sustainable, allow human touch in a safe way, while respecting the privacy of residents and families. Really feel like there's an opportunity here to start to develop things that are enduring and enduringly valuable. Next slide, please. The last opportunity I'm going to share with you really anchors around leveraging community assistance. Many of these facilities are quite constrained in both resources and available physical space. We're asking if communities can develop responses that utilize nearby outdoor spaces or programming to assist nursing homes in easing some of the challenges with the lockdown, including ideas like using local parks and blocking out specific hours for use by nursing homes, like the way you see local grocery stores preserving certain hours for seniors. So that's a quick tour through a sample of the strategic opportunities. Next slide, please. I want to close with a bit of a reflection. And when we started this work, it was to contribute to the goal of reducing illness and death in these long-term care facilities, and to look for strategies and approaches. And a few things have arisen. Next slide, please. We essentially did the unthinkable. We stopped the U.S. economy, and it's really forced us in many ways at a community and societal level, but also at individual levels, to sort of pause and reflect. And as we approach the start of the 87th Texas legislature, there's a chance for us to press some big ideas into motion. Next slide, please. And I'll just highlight them here for you to ponder and maybe to mull over. But a few thoughts here. One is when, if ever, we should prioritize a person's quality of life over infection control. It's a tension that we feel and are trying to manage in this moment. But it's a broader question I think we should consider. At a societal level, people are growing ill and enduring with those illnesses for a longer period of time. And it's really a question of whether or not we're providing appropriate, practical, and affordable long-term care options for a lot of that aging population. A third thought here is about whether or not the behaviors and practices we're actually incentivizing in the long care system actually match with the realities of the facilities themselves, and whether actually we're being thoughtful about what those facilities are capable or designed to do. A fourth thought here is about how we communicate with each other within the system. We are seeing a number of breakdowns. Is there a way for us to really augment coordination and collaboration in a moment of stress, but even when the pandemic passes? And then finally, how we essentially as a society rethink our aging population and how we take a more community approach around the kinds of facilities that we have in place. So I'll end with the next slide, which is just a note of gratitude, really to the city's commitment to this cross-functional collaboration. The collegiality of everyone we've worked with in the city and with other stakeholders has really made this work immeasurably better, and for that we're grateful. We also want to thank the partners that continue to make this project possible, the steering committee who continues to serve selflessly, and then to the Michael and Susan Dell Foundation, who has committed substantial funding to see this work continue. So I'll close there and be happy to entertain questions and discussion.
Thank you. Councilmember Kitchen. Recognize you first.
Thank you. I think this is, I'm very impressed with the work that you have done here, and impressed with the practical approach that you are taking to point out what can be done and the emphasis on action. And so I appreciate that. And I appreciate that you're putting this in the format in a way that we can consider our role as a city. And our role in partnering with the state, for example, and with the county. And I really appreciate that. And there were, two things that you pointed out that really strike me as something that's important for us to think about. And they're not unlike what has happened or what we've learned from other aspects of COVID. And that is the inequitable impact on our society. We have just seen, we've seen countless examples of inequity that we know exist, but the impact of COVID has just highlighted those for us. We are a population that's getting older, and we, a while back, we began to talk about the silver tsunami in Austin. And one of the two things that struck me about what you said is the inequity in access to options for aging. The fact that we don't have affordable places for people to age. We don't have affordable places geographically. We don't have them affordable in terms of what people can pay for. And so what you see is the lower income folks end up in nursing homes, which offer the lowest level of pay for staff and also the lowest levels of amenities, and aren't available as much. And so the other options for aging that may be available, those are higher cost, and there's an inequity there. So I appreciate you bringing that up. It also impacts our staff throughout the city, and there's a large workforce who work with older folks in different settings, and they are lower paid across the board. They are minorities across the board. A lot of times there are immigrant families. And so this whole system is just a microcosm for the inequities in our city. So I appreciate the practical things that you're bringing forward here. And I'm going to ask that as you continue your work, that you present to our Commission on Seniors. Our Commission on Seniors can help think through, and we'll want to spend some time with you to help think through the recommendations that you're making, and may have and help us think through as a council what actions the city can take. We're already moving forward with some of the actions related to staffing in the recommendations that we included in our agenda, our legislative agenda, that relate to level of pay and other things. So that's a long way of saying I really, really appreciate what you've brought up, and I look forward to working with you. I don't know if you want to make any comments about the inequities that you saw, but if you do, this would be a good time to make any further comments you might want to make.
Thank you, Councilmember Kitchen. I will make two comments. One is the inequity is clear both from a data standpoint. You can look at maps and see where the gaps are, but I think they're more clearly felt when you're actually in the facilities. It's actually quite clear. It doesn't take a rocket scientist to see the disparities in the quality of the care and the quality of the experience, and really the difference between essentially the haves and have-nots was quite stark when we visit those facilities. The other comment I'll make is I really welcome the opportunity to gain the perspective of the Senior Commission, and I think in addition to gaining perspective, they might actually be a partner in acting on some of these solutions as well. So I appreciate the introduction and look forward to that.
Thank you.
Thank you. I want to thank the Dell Foundation for picking this up. I mean, one of the most exciting things I think about this is that the city put in the initial seed money. Councilmember Kitchen, thank you for your leadership in pushing this forward. But having now done this work, it's great to see that it's being picked up by the nonprofit world, the foundations to drive this. And I think this is one of those examples of how we come out of this COVID as a better positioned community than we went into it, if in fact we'll actually realize the work and the suggestions that are being made, especially with respect to justice and equity in our city. Colleagues, any more comments on this before we get to the SAVE briefing? Councilmember Harper Madison.
I just want to echo your sentiment about Councilmember Kitchen's leadership here. She's been a tireless advocate, and it's so important. We had a conversation recently about a complex for our seniors and that deep affordability. And I just keep, the comment that somebody made just keeps resonating in my mind about affordability, like this deep, deep affordability. But we also, I'd like very much to not miss the opportunity here to bring this before the Health and Human Services Committee. I think this is, that's another committee that we would have a good opportunity. I think maybe the conversation with the commission could inspire the presentation for the committee. So I'd like very much to see that happen. And then as a final measure, as we're talking about these sort of sanctioned facilities, we have some complexes for seniors across this city that are in deplorable conditions. I mean, it's bad. And so my hope is that we can extend the conversation to those complexes as well, that we don't sort of limit our options to advocate for our elders. So Stacey, maybe you and I can connect offline. I'm not sure exactly how to really relay what's going on with some of these other complexes. It's a very important introduction to the conversation, in my opinion.
Thank you. I look forward to that.
Thank you.
Colleagues, anything else before we go on to SAVES? All right, thank you very much for the presentation. Dr. Chang, thank you for being with us.
My pleasure.